Assalamu alaikum. First of all, I would like really to thank my dear colleagues and friends, Dr. Mustafa and Dr. Kamal, for inviting me and the organizing committee as well. It's always a pleasure to be here back in Dhaka, and I see the progress in the conferences year after year. So I wish you all the best in that. Yeah. So my talk today will be about the role of SPRT in really a category which is very risky a bit, which is the central and ultracentral lesion of early lung cancer, and that is the non-small cell lung cancer. So I'll be just touching about the incidence globally and in Bangladesh about lung cancer, role of SBRT in central and the ultracentral lesions, and also the technique, what really technology we need to do before starting any SBRT, especially I'm talking about the central, ultracentral. And the other question, can SBRT really be considered for the operal patients for patients with these lesions, and some conclusive remarks. Now, this is the latest GloboCan 2022 report. And as you can see, this is the first time in history that lung cancer is number one and not breast cancer. Before a few years, actually, breast cancer was a bit more than lung cancer, but the latest report showed that lung cancer is number one now, and in the male and second female, but both in male and female, it is number one. So we can see the increase in the incidence, especially in low and middle income countries with the increase of tobacco use, unfortunately. Now, looking at Bangladesh about in this report, Globocan 2022, as mentioned, yeah, I think yesterday, you have, it's the projection number is about 167,000 cases, and the mortality about 116,000. Now, here in Bangladesh is number three most common cancers according to this report in males, but it is out of 10 in female, but in both sexes actually it is number three. So really there is a problem of lung cancer here in Bangladesh as well. So talking about the SPRT for the early, and when we say early, it's T1, early T2, the lesions ideally to be treated by the SPRT less than 4 or 5 cm. You might have such during diagnosis and staging patients of this lesion, so what to do, whether to go for surgery or the SPRT, and if surgery is not possible, whether the patient is unfit or refuse surgery, what to do. Should we really consider the conventional way, 60 to 66, or to go for SPRT? So this is the latest, the 8th edition of TNM. So when we're talking about the early, it's less than 4 or 5 cm. So it has been known from 2010 that SPRT is the standard of care and not the conventional radiotherapy 60 to 66 for early lung cancer for those patients who are unfit for surgery or high risk for surgery, and or patients who refuse surgery. So it's out of question now. The SPRT is the standard of care and not the conventional way of fractionation. Now, and we have also now some emerging data that I'll share it with you about the ongoing studies and some results also for operable patients. So now these are some of the landmark studies which showed that SPRT is the standard of care and not the conventional one. The Chisel phase 3 trial that compared 54 in 3 or 48 in 4 with the conventional one 66, and you can see clearly that the local control overall survival is much better when you consider SPRT rather than the conventional, because by giving these doses, the radiobiologically, it's actually more than 100. It's almost 106 or 110 gray that you give it in just 4 or 5 fractions. And we know from 2010, many publications, when we shifted really our practice to the SPRT from 2010, many studies like the RTOG 0236 showed again the same thing. And from that time, it was known SPRT it is the way to go for medically inoperable patients or patients who refuse surgery, with a very good local control that almost 95 for 3 years, and also with the around 90 persons overall survival. And you can see from the NCCN guidelines from that time till today, this is the latest one actually, that showed that for early lung cancer for patients who are inoperable, and of course, when we say early, it's N0 and M0, that SBRT and not the conventional way, that to be considered for those patients, and the doses to be selected should be more than radiologically effectiveness dose more than 100 gray, which is really important. And it's mostly common use, as you mentioned, it's mentioned there, less than 5 cm. That's the best result that you can have. Now, the 100 gray or more than 100 gray, the RP equivalent usually can be achieved by these doses, which is usually used 50 or 48 in 4, and this is actually the most one used, and that's for the peripheral. I'm talking about the peripheral: 16 3, 50 and 5, 45 and 5, and 40, 54 and 3. And all of them radiologically, they'll give you more than 100 gray. So this is good for the peripheral one. We know about the peripheral lesion, and it's safe to consider these doses there with very good local control and overall survival. The question is, if you have a lesion which is in the central or ultracentral lesions, would you really consider SPRT? Number one. Number two, if you consider SPRT, whether it will be the same dose as the peripheral or not. So when we talk about the central ultracentral, it means the lesions which are really close to the proximal airways, the heart, esophagus, and great vessels. And this is not the one usually you see in the peripheral zone. So this is actually some of the examples of the central and the ultracentral lesion. So if you have early one, what to do and what doses can be considered for these patients. Now, at the time, 10 years ago, it was known, Joe Chang, our friend from MD Anderson, actually, he wrote a paper and it was called as no-fly zone. Please don't touch this area with the SBRT. It's a bit risky. And most of the trials actually were conducted for lesions in the peripheral. And the definition of this, what we call the bronchial tree, which is the lower part of the trachea, the main, the right and the left bronchi, with 2 cm around. So this is what we call bronchial tree. Anything inside the bronchial tree is considered as ultracentral, and abutting these or close to the tree is called as the central one. So again, can we go and fly in this zone or not? Can we treat lesions there or not, especially for patients who are unfit for surgery or refuse surgery? So again, this is the same lesion that we are talking and the definition of the central and intracentral lesions. Why talking about this and the importance about these lesions? Because we know you might have a serious toxicities, including bronchial stricture and collapse, esophageal strictures and necrosis, tracheal, esophageal fistula, hemorrhage, and sometimes mortality. Patients may have hemorrhage while they are on table while treating, and also they may lead to death. So really you have to take care while treating such cases. Now let's see these lesions, how to deal with it. Now this is the publication about the outcome of the SPRT for central lung lesion. It's a systemic review with many articles, about the 20 publications for, and this was published in 2003. And the local control rate actually was good, about 85 persons in the central ultracentral, and it was the toxicity less than 10%. You can see here some of these 20 trials already in the central area, where the and the different doses have been used, like 16 8 or 50 and 5 or 48 in 8. There are different ones that have been used, and these are some of the possible side effects but that published in these articles. With a good overall survival and the local control also for the central tumors, roughly speaking, it's like the peripheral lesions. Now, this is another study, which is a new one in 2024, this year, comparison of SBRT in elderly patient. Can it be considered only for young patients? Or if you have some elderly patient with the central or ultracentral, can really use SBRT number one? And if yes, whether the same doses or not? And you can see here, there was no any statistical difference between patients who are very fit to go for SBRT in the central lesion or ultracentral or the elderly one. And this is, in my opinion, is really again for radiotherapy to be considered in these patients. And you can see here, statistically, there was no difference between the already published with the fit patients and elderly patients. So irrespective of the age, this still, the SBRT can be used for the central and ultracentral lesion. And the conclusion from this study was the outcome to the central versus the peripheral one in elderly patients was the similar, and the similar level of safety in both. So you can so this is an answer for the question in elderly patient whether you can use SBRT for elderly patients or not. Now, this is again a systematic review and meta-analysis for patients use the SBRT in the ultracentral region that within the bronchial tree. And these are many studies that have been conducted for the ultracentral within the bronchial tree, which at a point it was called no-fly zone. Nobody should touch that, but actually they had the courage to go inside, but to try to modify the dose to increase to reduce the dose per fraction and to increase the number of fraction, mainly 60 in 8 fractions. And they concluded SBRT as a treatment for ultracentral region tumors generally yields a high rates of local control, and toxicity rates may be acceptable, with the most common severe toxicity being radiation pneumonitis and hemoptysis. But still, there is some risk of severe toxicity, and SBRT can be used actually with some caution. Mainly, you have two factors you have to have before starting in your practice the SBRT, especially for the central ultracentral. Number one, the technology, the high technology. Usually, we use, of course, the 4D. I'll touch to that, and also the VMAT because it takes 2-3 minutes of treatment, and also the expertise of radiation oncologists, the medical physicist to give you a good plan, and the RTT to deliver it as well. So if you look at the latest NCCN guidelines about the central and ultracentral, it is there, it's indicated because we do have evidence and literature to support their use. Keeping in mind the presence of the technology and the expertise. And the mostly used one is 60 in 8 or 70 in 10. So we know in the SBRT, any number of fractions less than 10, especially 8 and below, it's considered to be the SBRT. And this is the most common use, and we use it when we started our SBRT back in 2015 with the help of Joe Chang from MD Anderson. So we treat all the central and ultrasound with 60 to 8. This is the safest one. And you can see this is good for the constraints for the as a reference for medical physicists when they do the plan to keep in mind about the organ at risk. To take into consideration. Now, again, this is a new publication. Just to give you some indications or some guidance about how to treat the central ultracentral, and I really advise you all to go and to read it very well in this and to be a reference to your department. Now, like giving examples of these lesions, which they are in the central or the ultracentral, very close to the special organs in this region. So what would be the recommendation? So just a summary of recommendation of this important report, that for the ultracentral tumor, you may use 60 in 8 or 70 in 10, number one. Number two, for central one, again, 50 to 60 in 5 or 60 in 8. But actually, in our practice, for both central and ultracentral, we go 60 in 8, and it's mentioned in this report. I mean, you are doing still a right thing, but we don't go in 50 in 5, we do it in peripheral so far, keeping in mind that these doses actually radiobiologically more than 100, and this is what you need. But they warned us that don't use the three fractions. You may use it in peripheral, but don't do it in the central and ultracentral, and always use either the IMRT or VMAT rather than the 3D for these lesions. Now, talking about the SBRT, the technology that really we need a good tumor motion management. You need also the complex plan like the VMAT or the IMRT, not the 3D, and also that the patient should be really helpful that he can really tolerate this procedure. You cannot really ask the patient to lay down if he cannot lay down on the table for at least 20 minutes for planning and for treatment or CT simulation, and also without a continuous cuff that will not work. So selection of patients is really important. And the CBCT, which is a must. Without CBCT, without 4D, you cannot really treat your patients. And these are the procedures of the SPRT. The 4D is really very important. You have to see the movements of patients because we know it is not static like in the CT simulation or in the planning. It moves and moves a lot, especially when it is near the peripheral. These are some of the cases that, and this is our publication, Red Journal, how we prepared ourselves 10 years ago to do with international collaboration with the MD Anderson. These are some lesions before and after, which is 16.8 near the heart. And usually we do the PET scan not less than 6 months. But we do at 3 months the CT chest, but the PET scan you have to wait a little bit because of the changes there after radio. It will not give you really a good. These are some of the results of the treatment, how you can really see the outcome of the treatment after the treatment. For operable patient, there is some really very good news that there are some studies which have shown that the local control and overall survival is as good as surgery, and this is just to enlarge it. How we know in in operable patient that it can give you a good results, as good as surgery? The Russell and STARS trial try really to answer this question, but actually they closed early because most of the patient went for surgery. So what Joe Chang did, he took those patients who were in these two trials in 2015 and analyzed that, and he discovered that really and reported that it was as good as surgery in 58 patients. And even in 2022, he updated that, increased the number, and also, just 1 minute, please, and also increased the till 5 years. Now we have 5 years after enrollment of this, and it showed the same. At 5 years, the overall survival was same as surgery. So we have now evidence to consider it even for the operable patients, although there are some trials which show these three trials, well-balanced trials, the SBRT tooth and the stable and velar, to finally answer this question. And in my opinion, that probably in the coming 2 to 3 years after we have the results of these trials, probably in my opinion, that surgery will, SBRT will be offered as surgery even in the operable patient. By this, I finish because the time is finished. Almost I'm off. Thank you so much.